let me do overview again of how we absorb glucose from our diet and how it's utilized by the processes of glycolysis. So as I was explaining initially, we're going to pretend this is your GI tract. And from your diet, you will basically eat, right, starch, or any polysaccharide. And as you are consuming this, your enzymes, specifically amylase in your saliva, and then your pancreatic amylase will start to chop up these polysaccharides and hopefully starts to, break them down into monomeric forms, into monosaccharides. Monosaccharides being, glucose. Right? And as your glucose comes into your GI tract and as it's essentially being broken down, it will be uptaken by the hepatic portal veins. So you have connections here that go to your liver. We'll say these are hepatic portal veins, which lead to the liver. I'm going to draw a liver here. And liver has two lobes. And in the liver, there's hepatocytes, right? The liver cells. And from the liver, then you have a hepatic vein, which basically goes to your circulation. So here, this is hepatic vein, and this leads to your general circulation. I'm just going to draw general circulation with red color, even though we have both venous and arterial, but this is your general circulation. And from the general circulation, we're going to say you have different types of cells. These could be any types of cells, right? Could be muscle cells, could be liver cells, could be your renal cells, cardiac cells, and so forth, right? So I'm just drawing random cells here. Why? Because from here is where the glucose and nutrients and also oxygen will be supplied to the tissues, right? So we're going to say these are your cells. And the other compartments that I want to emphasize in here, right, in between cells, we have the extracellular fluid. And inside the cells, we have intracellular fluid. The space that's surrounding these cells is also called interstitial space. Right, so the interstitial space is the space that surrounds all your cells. Another name for it is the extracellular fluid. And inside the cells is going to be intracellular fluid. So as we were speaking particularly about glucose, as your glucose is making its way, right, it gets reabsorbed by the liver, by the hepatic portal veins, right? And this glucose, when it comes in here, the liver can basically choose to do a couple of things with it. It can store it as glycogen, right? For later use when your sugar drops, or it can essentially, right, send the glucose to the rest of your cells if they need it. What liver can also do if you have other sources that are coming in, right? Let's say you ate some fruits and your enzymes chop them up into fructose, or you have galactose, which is both monomeric forms of sugar, right? They can be taken up by the liver cells, and the liver cells can convert these monosaccharides into glucose. So you could take fructose, galactose, and it can basically make glucose. Glucose is like our currency, our cash currency to drive metabolic processes of the cells, right? So majority of the time, glucose is like the most important fuel for our cells, right? And the body is going to basically employ it to drive glycolysis, which is the major form, right, that is going to employ. So we have glucose that's basically is coming here, and it's going to come to our general circulation. Now, if I pull out a glucometer and I check your blood glucose, we're going to say you are, after you ate, right, and it's been some hours, you do not have any pathophysiology processes going on, and you don't have diabetes or anything like that. If I check your blood sugar, it should be between 70 to about 110 milligrams per deciliter. Right? We normally walk around, between 80 to 100, roughly around there, depending on the state, if you ate or you have not. One important number which you should commit to memory in your REMAC protocols, especially for us to intervene with dextrose or glucagon medication. Who can tell me what is the number per the REMAC protocol for us to intervene?
60.
Yeah, less
Below
than 60.
60.
Yeah, below 60 milligrams per deciliter, I would commit that number to your memory. So this is when it's they consider it hypoglycemia. And while we're on this topic, those patients, they say, who are diabetics, they give them between 60 and 80. So if you have diabetic history, if your sugar is around this range, you could still be hypoglycemic, so you could still intervene, right? It's not a hard cutoff below 60 for everybody. So if you have diabetic history, right, 60 to 80 is your number, right? But let's get back to our 70 to 100, right? So in those, in the videos I was explaining, right? So inside the circulation, 70 to 110, but when the sugar comes out the circulation with the capillaries, right, into the extracellular fluid, more particularly the interstitial space, right? Do you suppose the amount of sugar that's found here versus here, is it different or the same? So if it's inside circulation is 70 to 110, what do you suppose it's in the interstitial space between your cells? How much is it here? Is it more? Is it less?
It's the same.
It's the same, right? Very good. So correct. The sugar can equilibrate between these compartments. So your extracellular fluid would be also about 70 to 110, depending, of the uptake of cells. Like, for example, if this cell requires glucose and starts to take up, this glucose, right, more will be coming out in order to replenish the stores. But my next question goes, right, in terms of interstitial space versus intracellular fluid. So we said extracellular fluid or interstitial space was 70 to 110. What about from this space to inside the cell? Is it the same or is it not the same?
Nah, it's different. I think that is lower than what it would be.
Right. So correct. So the answer is it's not the same, and it depends on essentially the requirements of that cell at that particular time. Does it need to drive glycolysis forward, or it has enough energy and it's not driving glycolysis forward? So it's really dependent on the cell that we are talking about. And the other very, very important thing is that we said here, right, the glucose can go in and out, right? It doesn't need any transporters. But for your cells, for all your cells, glucose cannot just go in and out like this. The cells need to have specific transporters, and it's cell specific. So for the glucose to enter the cells, it must have transporters. So the ones that you need to be familiar with, we call them glucose transporters, and the abbreviation is GLUT, right? Glucose transporters. And the ones that I want to talk about here will be 5 types: 1, 2, 3, 4, and 5, right? And some of these are found on certain tissues and others on different tissues. So glucose transporters number 1 and glucose transporters are number 3, right? They're predominantly found on red blood cells and your central nervous system, being your neurons. This is glucose type 1, right? Glucose type 3 also you see on the central nervous system. You see in placenta, right? And these transporters, type 1 and 2, they're non-insulin dependent. So you don't need insulin to facilitate the movement of glucose into these transporters. So what I mean by that, so let's say this is your neuron, right? And it will have these types of glucose type 1 and 3. Let's say this is glucose type 1. It will see the glucose here, and with facilitated diffusion, why is it facilitated? It's facilitated through these GLUT1 receptors. It will facilitate, not receptors, transporters, right? GLUT1 transporters. And it will move, right, glucose from high to low concentration, but you need this in the membrane, right, in order to facilitate it. Then my question goes, right, you notice glucose transporters 1 and 3, we see they're found in a lot of tissues, but the predominant ones are red blood cells, right, your central nervous system, and they're not under influence of insulin. And why is that important? Why should they be uptaking glucose from the extracellular fluid without utilization of insulin?
Because the brain needs a fast uptake of glucose. It cannot depend on insulin to release it into the cell.
Yeah, absolutely. Because a lot of processes, right, are being driven with glucose specifically, right? I'm going to explain a bit later, but we're going to learn this process of glucose uptake is going to go into glycolysis for ATP generation, and ATP is needed to drive a lot of metabolic pumps like sodium potassium ATPase in our cells, right? So brain cannot succumb, right, to lack of insulin, because if that was the case, the patients who have diabetes and especially type 1 diabetes where they don't make insulin, right, they will essentially not be able to get any glucose into their central nervous systems, and they will not be able to drive these processes. So that's why it's not under the influence of insulin. So glucose type 1 and 3, right, glucose type 1 especially found in red blood cells, and central nervous system, glucose type 3, central nervous system. And the same thing for the placenta, right? We don't need insulin in order to facilitate the uptake of glucose for the fetus in the placental tissues, right? The next one I want to talk about, right, is glucose type 4, right? Glucose type 4, these are your insulin dependent. This is insulin. And where you see glucose type 4 is you see them in the muscles, right? And you see them in adipocytes being the fat cells, right? So we see this in fat cells, adipocytes, and we see this is in muscle. And here we need the we need insulin in order for the glucose to come in. And the way this works, right? I'm just going to make another muscle here. I'm going to make this a little bigger, right? So inside your muscle, you have these vesicles which have glucose transporters type 4 on the surface. And there's a lot of these vesicles in here. And before insulin binds, they're not expressed on the surface, right? They're not expressed on the surface. So these are glucose type 4 transporters. On the cell surface, you do in fact have insulin receptor, right? So you have insulin receptors here. And when we have high amount of glucose in our circulation, right, and also in the extracellular fluid, the pancreas, right, the pancreas, specifically beta cells of the islands of the Langerhans, are going to secrete insulin. Insulin is a hormone that's being distributed by your circulation. When this insulin comes here, right, it's going to bind on this receptor. It binds in a state of high glucose. And when this occurs, it's going to trigger signals to basically go to these glucose type 4 transporters and start making their way to the cell surface. And so what happens, they start to move to the cell surface and they start to embed, right? So how it looks like this. So they make their way to the cell surface, and now you see the expression of these glucose type 4 transporters, right, on the cell membrane. So they will start to embed under the influence of insulin. So now, as you see, right, as they start to embed, then glucose can come in through these transporters and be uptaken for utilization, right? Muscles usually in high states of glucose, they store the glucose in form of glycogen. And fats store that glucose in the form of glycerol. And why do you need that? You need that in the setting, right, when you are starving, right, when you do not have enough glucose in your body, so that the body can call on the reserves in order to basically provide with the body, right? So muscles store excess glucose as glycogen. Fat cells, adipocytes, store excess glucose as glycerol. Both muscle and fat is insulin dependent. So for you to have glucose type 4 expressed on the surface, insulin must be present. If insulin is not present, they will not drive the uptake of glucose from the extracellular fluid inside. So insulin is a requirement for these cells, right? And glucose type 4 transporters are then basically mobilized to be expressed on the surface. Where do we get these glucose type 4, right? You know, inside your cells, you have a nucleus. In the nucleus, you have DNA, right? And then you have RNA. RNA gets essentially then makes messenger RNA, and then they make proteins. And these proteins, right, make these glucose type 4 transporters. And then with the response of insulin, they get moved to the cell surface, right? So that was glucose type 4. And then we have glucose type 2. Glucose type 2 transporters, the best way to remember this is two-way. So for number 2, remember two-way. So two-way transporters, right, the predominantly found on the liver, right, liver, and they're found on the pancreas. They make smaller size organ. So we're going to say this is the pancreas. And we see glucose type 2 found here, right? So we see liver has glucose type 2, pancreas has glucose type 2, right? And there are two-way transporters, meaning, right, you don't need any insulin to drive glucose in and out, and it can go both ways here and here. And why do you suppose these tissues, right, have this another organ that has it is the kidney, right? Why do you suppose these organs in particular has glucose type 2 two-way transporters, where glucose can go both ways?
For glycolysis and gluconeogenesis, I think.
So yeah, you are essentially on the right path, right? Yeah. So we have when we uptake of glucose, right? A lot of glucose in the body, right? So we uptake of glucose, we may store it as glycogen, and that done with these glucose type 2 transporters. So glucose goes in for the storage, right? And that process, the storage, right? The storage, we call it glucogenesis. So we basically store it in the form of glycogen, right? So glucogenesis, we make glucose, we store it as glycogen to call upon when we need them. And we need those two-way transporters, right, for that reason. But in the states, right, where we want to mobilize that storage, right, we want to break it up. We have a process called glucogenolysis. So glucogenolysis is breakdown of glycogen stores, right? And we use those glucose type 2 transporters, right, in order to release that into our circulation when we need to, when we need glucose, right? So glucogenesis was formation of glycogen stores. Glucogenolysis, lysis, breakage, right? If you have heard this word, cell lysis, you break the cells. Glucogenolysis, breaking of glycogen stores, right? And then, right, there's this other word called, let me use a different, gluconeogenesis. So what's gluconeogenesis? Can anyone tell me?
Neo means new, so
New, yeah, glucose means, so neo
It's-
means new,
it's
but
making new.
new what?
Glucose.
How?
Well,
Hey, Nikolai, can I get a stab at it?
Sure. Oh, go ahead, Brendan.
Basically, things like, from what I read, things like lactate and stuff like that, they transform that into new glucose cells.
Yes, very good. So, Brendan, you're 100% correct. So, neo, the word neo means, if you remember the definition, so gluconeogenesis, it means formation of glucose. So, formation of glucose from non-carbohydrate sources. And as you said, right, things like lactate can go in there, amino acids can go in there, fatty acids can go in there, right? So as we start to chop up these polypeptides into monomeric forms of amino acids, big chain fatty acids, right? As we start to chop them up, liver specifically, can be able to perform gluconeogenesis. Some of this is very, very important in the setting, right? When you have very low glucose in your body. And once these are formed, again, with help of glucose type 2 transporters, the body can then send it into the circulation, right? And then we're going to learn there's a process of glycolysis, right? Which is essentially what we're doing. We're making 2-pyruvate molecules, and the main goal, right, of glycolysis is to generate ATP from breakage of glucose, right? You chop up glucose, and the reason why I have all these terms here is that they become very confusing to keep track, right? So to go back and emphasize the distinction. So glucogenesis, the first one. Glucogenesis is storage, formation of glycogen as a lot of glucose is coming in. Then you have the process of glucogenolysis. You basically you break down glycogen stores, right, to get them into the bloodstream. Then you have the process of gluconeogenesis. That's when you already depleted, right, this part. And this part is probably within the first 24 hours, you're going to utilize all your stores. So then the body's starving. Then it has to employ this method, right, gluconeogenesis, formation of glucose from non-carbohydrate sources. And this is all of these three processes. They're distinct from glycolysis, right? Glycolysis is a process of formation of 2-pyruvate molecules from a single glucose, right, in order to make ATP. By the way, which cells in your body perform glycolysis?
I actually had a question, Nick, if you don't mind.
Yeah. Let me first address this, and then and then you could ask your question. What is as I was saying, which cells in your body perform glycolysis?
all cells.
All cells, right? So all cells in your body perform glycolysis, and ideally, after glycolysis, then if you have mitochondria and you have oxygen, they're going to go into oxidative phosphorylation in the mitochondria to make a boatload of ATP. But your red blood cells, right? Red blood cells, RBCs, they have no mitochondria. They also do not have a nucleus, and they do not have organelles, so no organelles. And that's important. Why? Because RBCs, they're bags of hemoglobin, and to maximize the surface area where hemoglobin can carry oxygen, they do not have mitochondria, they do not have a nucleus, they have no organelles, so more hemoglobin can load oxygen. And the other important factor being, imagine if red blood cells, right? If your red blood cells had mitochondria in it, right? Mitochondria wants to now use that oxygen to drive oxidative phosphorylation, but we need that carrier, right, to go to all the tissues. Like the equivalence of that would be like you utilize UPS, right, to ship your packages, or FedEx to ship your packages. And instead of them delivering it to the recipients, they were just collecting it for themselves. The FedEx or UPS was just collecting the packages for themselves, not distributing it. So that's why RBCs do not have mitochondria, so that they're good, a faithful transporter, if you will. They will take that oxygen and deliver it to the tissues. So RBCs, what you want to remember, they have anaerobic glycolysis without oxygen, without mitochondria. They're not going to obviously produce as much ATP as in oxidative phosphorylation, right? It's enough for red blood cells because they don't have excessive metabolic demands. So glycolysis, where you only make about 2 net ATP per glucose, is sufficient to drive the demands of red blood cells, right? So remember, red blood cells, no mitochondria, no nucleus, no organelles. They predominantly bags of hemoglobin. They have anaerobic glycolysis, and they have enough of utilization of ATP with that glycolysis. But all other tissues, for the most part, there's a few other tissues in your body that perform aerobic glycolysis, right? You have some in your cornea that don't need that, but overall, most of your tissues perform oxidative phosphorylation, where they do have mitochondria, they do have oxygen, and they basically then move that glucose to derive 30 to 32 ATP later on, right? Brendan, you had a question?
Yes. If I'm asking this right, if I'm thinking correctly, if the body, let's say the body is starved with like ATP or sugar, right? Does the body use like its own fat cells to try to produce that, such as like if a person was in ketoacidosis and technically the sugar is not getting in the cells because of insulin or low insulin, does the body feed like on its own fat to try to supplement that or break it down?
Yeah, exactly. That's exactly what happens. So in diabetic ketoacidosis, right, the body, it's basically, imagine the following situation. This is your circulation, right? And there is a lot of glucose, because if you check those patients' glucose, they'll actually have high glucose levels, 350, 450, right? So, and we said the extracellular fluid will have the same amount. So it could be, 350 milligrams per deciliter. But remember what we said, in order for it to basically go into your muscles and to go to adipocytes, right? You need insulin. You need insulin to facilitate that uptake, right? So if this is your insulin receptor, right, we need that insulin to bind here in order for glucose type 4, right, to start making its way to the cell surface. But the diabetic patients, depending if it's type 2 or type 1, let's say we have type 1 diabetic who is not making any insulin. So they don't make any insulin. So if they don't make any insulin, all this glucose is now in the extracellular fluid and it's not making its way to the cells. So the body thinks, right, it doesn't have glucose, even though there's a lot of in circulation. So the body starts to break up, right, through the process of gluconeogenesis. It starts to make glucose from non-carbohydrate sources. You also you could make ketone bodies, right? Ketone bodies, which basically make you more acidic, right? And this is why they succumb to the diabetic keto, right? Breaking down ketones, ketoacidosis, and it's very acidic in our body, so you drive your pH down. And very important, right? Even though there's a lot of sugar in your bloodstream and in your circulation, the cells do not see it. It doesn't get uptaken because no insulin. No insulin is bound here. The patients who have type 2 diabetes, they have resistance, so their receptors are not as functional. So even though they do make insulin, these receptors lose affinity, right? So the insulin doesn't bind there, or you need way more insulin to trigger that response. So yeah, those patients start performing gluconeogenesis. And by the way, for those patients, when they come to the hospital, the main reason we give insulin, the main reason you give patients who have DKA insulin. Well, let me ask you, what is the main reason you give insulin for those patients?
Well, for one, you want if you want the metabolic terms, you need the sugar to start entering the cells.
Yeah,
because
but
there's too much sugar.
Yeah, you want the sugar to enter the cells, but the main reason we give them insulin is not to drive sugar into the cell. The main reason we give them insulin is that you want that process of ketoacidosis, right? The formation of ketones and breaking down of non-carbohydrate sources to stop. The only way you could do it is for the body for the cells to essentially say, okay, we finally have the glucose. So the major reason for driving insulin is not to drive glucose into the cell per se. The main reason is to stop the ketoacidosis going forward. So that's why we give insulin, right? So hopefully that answers your questions, unless you have any more.
No, that perfectly answered my question.
Yeah. So that's the case, right? So any questions about this 1, 2, 3, and 4, what the differences between them, right? So they're not the same, right? Very important to keep these processes in your mind when you talk about the stuff, especially when we do endocrine. They're gonna play a big role. It's not, the difference is not the spelling, right? So if I ask you what's the difference between gluconeogenesis versus glucogenesis, it's not just the spelling. It's, you know, there's a difference in terms of the processes, right? Any questions there? All right. So if there's no questions there, we talked about all these transporters. We talked about all, you know, the final aspect of it, right? So now, you know, all this talk, right, about utilization of glucose, we finally come to the process of glycolysis, right? So glycolysis. And I know when you study this, you know, they start to show you these charts, right, where it's like, it's ridiculous in terms of you have all these intermediates, you have all these enzymes, right? But I want the big picture. I want a big picture overview, because if you start, you know, explaining this to me in terms of molecules and enzymes, I have no clue what's going on. The major point, right, of glycolysis is this. We took this polysaccharides, we took these starches, right, pasta, whatever you ate, you broke it down to glucose, right? So glucose is your single, right, monomer. Or you could say it's mono sugar, right? And then from this glucose, from one glucose, what you're gonna do is you're gonna make 2 pyruvate molecules. With this glycolysis, right, as you make 2 pyruvate molecules, here you will generate net 2 ATP. So net means some you invest in the process, but overall you get 2 ATP, right? And also you're going to do the following. You'll take this molecule called NAD+. It's basically, this molecule is a carrier for your hydrogen, right? Hydrogen carrier. And you make it into NADH, right? Where do you get this hydrogen from? You get this hydrogen from the glucose, right? Because if you look, right, even though, you know, I hate to do this, but I will just draw it here so that you understand, right? So this is your glucose molecule that has 6 carbons. So you see all these hydrogens, right? So I'm going to circle in red all the carbons. So 1, 2, 3, 4, 5, and 6. So you have 6 carbon, and you have all these hydrogens, right, that are attached, which is going to be employed, right, in order to drive the process of forming ATP. So this NAD, which is a carrier for this, right, this is where it extracts it. It basically grabs it from glucose, and this is our D-glucose molecule. Now, if you do not have oxygen, if you do not have mitochondria, right, you basically come to this 2 pyruvate molecules, like, for example, in your red blood cells, and that's where you end up. You basically make net 2 ATP, right? But if you have mitochondria, right, so we're going to say this is your mitochondria, right, with the outer membrane. And if you do have mitochondria, this pyruvate can then, right, be going into the mitochondria, is going to be turned into acetyl-CoA. And then with the Krebs cycle, in the Krebs cycle, you make way more of this NADH, FADH2, and what they do is they're carrying your hydrogens. They carrying all these hydrogens, right, as you break down sugar, and they're carrying it to the membrane of the mitochondria to drive the final process of the electron transport chain. And with the electron transport chain, you're basically creating a gradient. you're creating a gradient where you're pumping this hydrogen into this mitochondrial membrane. And as the more hydrogen is now in the cell surface, right, you have a gradient change. There's a lot of hydrogen outside and very little hydrogen inside. In this membrane, there is another in the electron transport chain, there is something called ATP synthase. And what it does is it will basically take this hydrogen, drive it inside, and this will power its turbines, like it's rotating. And as it's rotating, it's going to be generating ATP. And as it's generating ATP, right, with this process, with the electron transport chain, it's going to make about 30 to 32 ATP. So you see the difference, right? Here, we only made 2 ATP with anaerobic glycolysis. So anaerobic glycolysis makes 2 ATP, but in the presence of O2 and mitochondria, right, we make about 30 to 32 ATP. Right? So which one do you want your cells to be doing? Do you want them to be doing oxidative phosphorylation, making 30 to 32 ATP, or do you want them to be making only 2 ATP with anaerobic glycolysis? Which one would you prefer?
Thirty to 32.
Yeah, 30 to 32. And remember in the neuro chapter, right, and in the muscle chapter, I was explaining to you, right, you had the cells, right, where you had impulse propagation, and I said in order to restore your gradient on the cell surface, we had these sodium potassium ATPase. And the goal of the sodium potassium ATPase was to basically get rid of 3 sodium and then bring 2 potassium inside. How much, let's say your body, after doing this glycolysis business, you have 100% storage of ATP. How much you think this process of this alone, just that sodium potassium ATPase on your cells to restore that gradient, how much percentage-wise ATP they use? Just this process alone.
Probably like 25%.
Yeah, 25 to 30%. So 25 to 30% of ATP is used on this. Why? Because you need 1 ATP molecule in order to drive 3 sodium out and 2 potassium in to restore that gradient. So 20 to 25 to 30% of your ATPs are being utilized by this process. And it's so crucial to understand this is that in a setting of shock, right? In a setting of shock where you have lack of oxygen. Why? Because you may have either, issues with your lungs where you have problems with diffusion, or you have such profound vasodilation, your blood pressure drops, and your blood pressure dropping is not allowing enough perfusion to your organs. If I don't have enough perfusion to my organs, the organs start to switch to anaerobic metabolism. Anaerobic metabolism means I'm not here. I'm not making 32 ATP. If I'm not making 32 ATP, it's hard for me to drive this process and all other processes that require ATP in your cell. So if this is occurring, right, person is going to do what? They, instead of going down this pathway, they're going to take this pyruvate and they're going to start to make lactate. And we could actually measure this, right? We have point of care testing. We could measure lactic acid. Normally, this value, right, depending on the book you read, could be 1 to 1.4 millimole in your blood. Why? Because some cells, as I said, like the cornea, red blood cells, they do make lactate as normal process, right? But in the setting of shock, this is what's happening. You start to accumulate lactate and lactic acid. And so when we measure your lactic acid and this number is increasing, right, it's trending up. So maybe it's 2 millimole, 3 millimole, 4 millimole. That means that your tissues, right, are not performing aerobic glycolysis. They're switching to anaerobic glycolysis, and there's high demand of glucose and nutrients by your tissues, right, which your body is not meeting said demand, right? So the whole purpose of all this talk, right, that I was explaining is to explain this, right? We want to go here. But in the states of shock, it doesn't have to be septic shock. It could be any shock. If the shock keeps going on, you're going to go here, right? So let me just preview this for you, right? So this was published in 2012, and they said, right, your lactate concentration, the normal range, right, that we were talking about, they say here is about 1.4 to about 2.3 millimoles, right? Usually I would say 2.3 is a bit high. Maybe 1 to 1.4 would be, you know, the numbers you want to look at, right? And right, this was our normal glucose value, just to show you, right? 70 to 110 milligrams per deciliter, and your normal lactate level is about this much, right? 1 to 1.4. Now, this was glucose transporters. We'll get back to it, right? What I want to get to is here. In the setting of, right? In the setting of sepsis, right? They say the serum lactate is most important biomarker of tissue hypoxia. So what all of this that I was talking about is that the more lactate you make, the more you realize how hypoxic and dysfunctional your tissues are becoming, right? So that's why they measure lactate for your septic patients. So as the septic shock progresses, your lactate level is going to increase, right? So, and that's why they give you the first hour bundle. They say measure lactate level because you're going to anaerobic respirations, and they give you all these treatment modalities, antibiotics, giving IV fluids, right? Giving vasopressors, because you want to increase that blood pressure. Hopefully you drive, you know, the blood and nutrients, glucose to the intended organs, so they stop forming more and more lactate. So we trend that in the hospital, right? In order to, you know, in order to facilitate basically improvement as you provide your treatments. So lactate by itself does not make a diagnosis of sepsis. What lactate level means is that you are in deficiency, right, of glucose, and tissues are going into this hypoxic dysfunctional state. And the reason why we trend it, what's the importance of trending it? As you're providing care, right, hopefully, right, your numbers start to decrease. So let's say it was initially it was 5, then it starts to become, let's say, 4.3. As you're giving your antibiotics, as you're giving your fluids, then maybe it's 2.8 and so forth, right? Once this number starts to decrease, I know that my tissues are not now utilizing aerobic glycolysis. They're utilizing glucose, they're using oxygen, and the demands of the tissues are being met, right? Does that make sense? Yeah.
Yeah.
And these slides here, I will just go through it. This is just the pictures. I think they have, you know, a big level of detail, but I will just go through it in case, you know, this is just another way to representing it. So as we were saying, right, the glucose serum level was 70 to 110, right? The transporters that we were specifically talking about, right, which were insulin dependent, was type 4. And the predominance where they found is adipose tissue and muscle. So glucose type 4, remember, they're insulin dependent. You need insulin. This is going to become crucial when we start talking about endocrine chapter. The ones that are non-insulin dependent are all other ones besides type 4. So if you want to remember, type 4 is the only insulin dependent. The other ones is type 1, as you see in red blood cells, brain, right? Makes sense. I don't want them to be under mercy of insulin. Placenta also. I don't want the baby, right, to need insulin in order to extract the sugar. Glucose type 2, right? We said they're found in liver, they're found in kidney to do gluconeogenesis, right, and glucogenolysis. But also they found on the beta cells of your pancreas. Beta cells make, by the way, insulin. And that makes sense as well, because then the pancreas needs to be able to sense glucose in the environment. How does it know to secrete insulin? How does it know to secrete glucagon? Because it has glucose type 2 transporters, which are bidirectional. So it could sense, is it high sugar? High sugar, okay, let me secrete insulin. Low sugar, all right, let me secrete glucagon, right? Because the body's not mad. It needs to have regulation, you know. So that's how it does it, right? Glucose type 3, right, was similar to glucose type 1. We see it in the brain and the placenta, so central nervous system, Glucose type 5 is found in your testes, right? They're found in spermatocytes because that's to drive the movement, right, with the flagella. And also you see them in your GI tract. So these are the glucose transporters. The ones that I would definitely remember, which are going to be important, is glucose type 4, right? Glucose type 1, glucose type 3, which are kind of similar, and then glucose type 2. So, and which are insulin dependent and which are not. Right? From here, right, we said that the glucose basically entered the hepatic portal. This is your hepatic portal. Pretty much all your stuff is going to go through it. All your drugs that you're going to take, if they have the first pass through the liver, right? This is the uptake through the liver. The liver then decides what to do with it. If there's excess glucose, I'm going to store it in the form of glycogen. If there's low glucose, I need to basically move it further along. It goes further along into the hepatic vein. Then this glucose is going to go into your central circulation. And this is how it basically looks, right? From the GI tract, we come in, goes into the liver, right? And then it goes into the central circulation. Now, the whole business of all this, right, is that we then going to chop up all these multimeric forms, right, of peptides, lipids, and sugars, right? This is our nutrient pool, right? So you see them all coming in here. The whole purpose of all this, I want to drive this. I want preferentially, I want aerobic, right, in the presence of oxygen and mitochondria. Not always possible in the settings of shock, right? So we need this ATP, right, to drive, such as sodium, potassium ATPs. About 30% of it is being utilized, right? And then the books have these types of chart, which I think you kind of get confused by this, right? Because you start to see these enzymes and all these carriers, and you have no clue, what's going on. But I kind of explained the overall, story for you. I kind of gonna go some of the steps. They make sense if you start to study this. Glucose, right? We said comes into the cell, and then glucose 6, becomes glucose 6-phosphate wide, because initially you have the investment phase. We utilize some ATP in order to basically trap that glucose, so the phosphate gets attached to it. When the phosphate gets attached, phosphate is a negative charge molecule, so it doesn't allow the glucose then to leave the cell. And then this glucose is basically being chopped up. You see how it goes from 6 carbons to 3 carbons, right? And we are basically taking the hydrogen, loading it to NADH, which is going to go later into mitochondria, electron transport chain. And as the process goes on, we basically make net of 2 ATP. So we invest some ATP in order to drive this process. And then the bottom line, we make 2 ATP in just glycolysis, without oxygen, without mitochondria. So then it's going to go into the mitochondria. The major payoff is here. Here we only get 2. The cells that do that is red blood cells. And then in the setting of shock, when it cannot go further along, right? This is what you end up. Now, once you're in a mitochondria, it's going to go into this Krebs cycle, as I was saying to you. The whole purpose of this Krebs cycle is basically loading these electron carriers, right? NADH, FADH2, and then we're going to be taking all of them into our electron transport chain. So once we get them into the electron transport chain, right, you see all these carriers, and the hydrogen was basically uptaken from the glucose. It's going to go into the mitochondria, right, and hopefully with this gradient is going to pump hydrogen ions, right? So let me show you this one here. So as these carriers are taken in the mitochondria has 2 membranes. It has the outer membrane, has the inner membrane, and has this intermembrane space. That's basically, if I was to draw this mitochondria, right? So this would be the outer membrane. This is this here. The inner membrane is this here. And then the intermembrane space would be here. And as you see, right, there's different proteins embedded here. And as NADH and FADH2 is making its way along, that's why they call it electron transport chain, basically. it pumps hydrogen ions into this intermembrane space. So this intermembrane space becomes loaded with hydrogen. So high concentration of hydrogen outside, right? High concentration, and low concentration inside. So if there's low concentration, right, we see this here's ATP synthase. It's like a turbine that's going to rotate. So it's going to then move these hydrogen from the high concentration inside to the low concentration, and when it does it, it will rotate. By the way, the biochemist who discovered this, his name was Mitchell, right? He won a Nobel Prize. When he gave his proposal, people thought he was crazy for describing this process. But later on, when they did more experiments, they said, oh no, he was correct. So Mitchell was correct. So they awarded him Nobel Prize. Why? Because they basically, made fun of him and said, you're crazy. This doesn't work like that, right? But that's how it actually works. And you make, right, 30 to 32 ATP with this process. So this gradient is what drives your ATP synthase, right? And once this is done, right, this is the whole story. The whole story is this, right? You take one glucose, and with these processes of glycolysis, the Krebs cycle, citric acid cycle, and electron transport chain, you basically want to be here. 30 to 32. If you don't have this, you're only going to be going here. So this is where you go just with red blood cells alone or in the setting of shock. In the setting of shock, right, this is what's going to occur. Hopefully, with our treatments, we want to, bring this person back to this level. All right, any questions? All right, so if you guys have no questions, right, we're going to start with our short answer problem set, right? This just shows you, right, in the setting of shock, this pyruvate is basically taken into the lactate pathway. So lactate pathway, you make your lactic acid, lactic acidosis, right? And here it shows you, this sodium-potassium pump, right, which we talked about, which pumps, right, 3 sodium out, and it brings 2 potassium in order to drive the cell processes. All right, this pump alone, right? This pump alone is responsible for 30% of the body's ATP usage. 30%, right? So out of 100%, 30% is used on this pump alone. So that's very important, right? So the sepsis we talked about, right? So any questions before we proceed to our short answer format? Ian, would you like to go?
I just saw this, but I could try it, all right?
Yeah.
All right, so first, you receive a call for a sick patient in a nursing facility. Upon your arrival, unseen, you find a 75-year-old male patient, semi-Fowler's in bed, and is only responding to painful stimuli. The nursing staff informs you that the patient's normal mental status level is alert and oriented. However, the patient developed abnormal labs and spiked a fever, so they called 911. Upon your assessment, you obtain the following vitals. BP 68/32, heart rate of 122, respiration rate 30, with an SpO2 at 91, EtCO2 is 29, and utilizing nursing facility thermometer, the patient's temp is 102.4.
Physical exam?
PE reveals the patient. Physical exam reveals the patient's skin at the core is hot to the touch and cool at the distal extremities. You observe the patient has an indwelling Foley with dark, cloudy urine laying on top of the bed. When you ask the nurse what were those abnormal labs, you were informed that the white blood cell count was 25,000. Point of care lactate was 5 millimoles per liter. Okay. My presumptive field diagnosis is, I'm thinking sepsis.
Good. So yeah, we believe sepsis, and more particularly, I want to say we are in septic shock. Why? Because we see, right? We see that the blood pressure is low. We see that point of care is 5 millimoles, and we also see, right, he has a Foley catheter with dark cloudy urine, which is lying on top of the bed, which is already pretty bad, right? It should be hanging on the bedpost below the level, right, of your bladder. So yes, septic shock is correct, right? You may continue.
Is this patient having increased or decreased metabolic tissue demand? So it's lactic acid at 5, which means that's too high. So he's using anaerobic. Oh no,
Yes.
wait. What
Yes.
was it? Yes, anaerobic. Check my notes. Okay, so he's in anaerobic respiration.
Yeah. So would you say his tissues they're requiring more oxygen and nutrients, or they're requiring less? Yeah, they're definitely requiring.
They need more.
Yeah, they need more. Why? Because first of all, one of the reasons he has a fever, right? So anytime you spike a fever, you will definitely increase your metabolic demands. 2, he has low blood pressure, right? So the amount of blood is reaching to his target organs is diminished. So because the blood pressure is low, right, the body is not basically getting that supply. So we have increased metabolic demands, and they're not being met right now, right? Okay, now we're gonna go to C.
Yes, well, this means the lactic millimoles are too high. It should be, like you said, 1 to 1.4.
Yeah.
So what does that mean? It means what we just talked about, basically, right? This is proof that he's having an increased metabolic tissue demand.
Exactly. So his instead of going to oxidative phosphorylation and pyruvate making its way down, right, into acetyl-CoA and into the mitochondria, what actually happens is it's going to become lactate, right? The enzyme that does it is called lactate dehydrogenase enzyme. It basically takes the 2-pyruvate that you made from glucose and is going this way. And this is what driving this, right, lactate level to go up. And this is what we're trying to basically treat, to trend this number, and hopefully with our treatment, this number, starts to decrease, maybe 3, 2, 1, and then hopefully get it into the normal range. Yeah. So high point of care lactate tells you that his tissues are hypoxic. So that's what I want you to understand. His tissues are hypoxic. They are under increased demand, and the demand is not being met. So very good. And number D.
Okay, what type of respiration? Well, we just answered that. That's anaerobic.
Anaerobic is correct, right? Yes. And the final E, right? What is the significance of high respiratory rate and low end-tidal CO2? So let me just write normal values so you guys remember. So roughly speaking, respiratory rate is about 12 to 20 breaths per minute for your normal person, roughly speaking. And then your end-tidal CO2 normally is 35, 45 millimeters of mercury. So this number 29 is low, right? This 29 is low. So what does respiratory rate of 30, which is too high, and this number of too low indicate?
Well, I think that he's trying to blow off. Is he trying to blow off the CO2 and it's not working?
Yeah, he's trying to. Why do you think he's trying to blow off his CO2?
Because there's too much in his blood, but it's not coming out.
Why? Yeah, why is there so much? Why? You're correct, but my question is why?
Because the respirations are anaerobic.
So truly speaking, why? So why? Because you have this. See how you have lactic acid a lot?
Yeah.
So you have a lot of lactic acid, right? The whole purpose, right?
Acidosis.
Yeah. So we talked about this formula, right? So the whole point being, we have a lot of this. We have a lot of hydrogen. So for us to compensate, we got to move this way. So if we move it this way, we got to make more CO2 to basically compensate for this lactic acid that's found in our circulation. And to do that, we need to increase our respiratory rate. And by increasing our respiratory rate, you're going to blow off a lot of CO2 in your lungs. You're going to blow it off. If you're going to blow off CO2, you're going to decrease your right, and tidal CO2. So this is respiratory compensation for lactic acidosis that's found in your circulation. Make sense? Yeah, so those, a little tip for you guys, right? When you are coming to a nursing facility, for example, they say, oh, we've got a sick patient, you know, you took their temperature, it's elevated. And if you put your end-tidal CO2 on them, right, end-tidal CO2, and you count the respiratory rate, so you'll say, okay, end-tidal CO2, you know, 29, 30, below this number, it will tell you on your monitor, right? And then you see your respiratory rate is 28, 30, 32, right? Even if you did not have, let's say, point of care lactate, right? All you had is a temperature, all you had is this number, right? And perhaps you had a Foley or some other thing that gave you a little proof, like here involving Foley. Maybe they have, you know, abnormal lung sounds. Maybe they're on a ventilator. Maybe they have a, you know, peripheral inserts catheter, right, PICC line, and you see cloudy or dark or purulent fluid around it, right? That could give you an idea, right? Oh, you know, still, maybe this person is having sepsis or septic shock, right? At least you could say the person meets the SIRS criteria, SIRS being systemic inflammatory response syndrome, right? So at least that alone can help you, right? And you'll say, all right, so we need to get this guy treated. We gotta, you know, start IV access, give him some IV fluids, and, you know, notify the hospital so they can get their antibiotics and everything else ready. All right. Any questions about this?
Yes, Nick, I have a question.
Yeah, go ahead, Helmi.
This is called metabolic acidosis. That's correct?
Yes. So okay. you depending if I drew their arterial blood gas, right? ABG. This can tell me, right, the numbers. It will tell me their pH. It's going to tell me their PCO2. It will tell me their bicarb level, right? It will tell me their PaO2 level, oxygen level. So if I drew their arterial blood, I will get these values. And from these values, I can tell if they're acidotic, and I can also tell based on these values if they have any type of compensation. And this compensation can be respiratory. So usually you may see, right, they will have metabolic acidosis. Metabolic acidosis. Why? Because they have a lot of lactic acid, and they'll have respiratory compensation. Respiratory compensation with respiratory alkalosis, because they're trying to blow off the CO2 in order to drive pH back into normal range, which is 735 to 745.
Thank you.
Yep. Any other questions?